Cette chaise-là, je vais la mettre derrière.
Okay.
Le micro, en fait, c'est pas nous, hein.
It's very impressive with the camera.
Yeah.
Bonjour.
Mais le plus fort possible. Voilà. Il y a une chose
Ça peut changer.
Carmen, let's start
On commence et puis le temps qu'on présente.
Good afternoon. Welcome to this session organized by the GAPF Network. So today we are going to discuss about improving access to better medicine for children. So I am Ekwevi. I am working with the Elizabeth Glaser Paediatric AIDS Foundation. So last week during the pediatric HIV workshop, a question was asked to the participants. Do you ever feel that the drugs you need for a neonate or children is it the appropriate one you have, or is it optimal? All the participants raised their hand to say no. I'm pretty sure if we ask you the same question, it will be the same answer. But having a pediatric formulation friendly for children is not an easy thing to have, because there is a lot of challenges you need to overcome. The first one is related to the prioritization. Which drug we need to develop first. The second one, as is for children, we need to have the best formulation who can be used for all the age group. We need to take into account the flavor, we need to take account the taste, so it's not easy. For pharmaceutical industries, what is the market for those drugs? And at the end of the day, the cost coming from research, advocacy, regulatory affairs, but also is really when you have difficulties to overcome those difficulties. And the joint effort of all those organizations is really to be able to make available in a very fast manner a new friendly formulation for children. We have the drugs, but it's not the end of the story. We need to make this drug available for each beneficiaries. And at this stage we have the product access tech treatment working group, in which you have the PDTG, now the PLD task team. And this task team, the role of this task team is to develop specific tools to guide programs and other stakeholders at country level for the introduction of the drug. But also in terms of advocacy, capacity building, identification of the need, and after the introduction of the drug, monitoring the rollout. We have the drug. We know that is a famous drug, the PLD, the PDTG, but we still miss some children. 50% of the children are not on ART. For those who are on ART, only 48% are very suppressed. This is not acceptable. It is not acceptable. We need really to improve it. And it's the reason why we need each of you to be part of this journey in terms of improving access to drug for aged children. So I would like to give the floor to Sebastian going to talk about the PRD. After that, we are going to see how the community could help to improve access to the drug-friendly, children-friendly drugs. And after that, we are going to see the new advocacy brief is developing regarding to better access to children. So, Sebastian.
Thanks very much. Good morning, good afternoon, everyone. First of all, I'll welcome Tabitha, who's finally here with us, so that's great to have her. So I want to start with, if you can change the slide, please. We forgot to bring a clicker, but you can load the full slide, please, once again. Yes. So as Patricia was mentioning, we've been through what we can call a fairly good success story for access to pediatric formulations with pediatric dolutegravir, the single tablet that's dispersible and scored. In 3 years, we reached 95 countries. We reach a very large majority of the kids on treatment, and that was made by not a single organization, but a very large number of organizations that were acting in a coordinated manner. And at GAPF, we've been supporting this process by identifying issues in rollout, for example, and addressing these with memos, with targeted advocacy and engagement. So this has been a real success story, 95 countries, but there's still 40 countries that could access the generic dolutegravir single that haven't started rolling it out. So there's still a gap. But for these countries, as well as for the others, there's an opportunity right now. We have a new formulation that combines abacavir, lamivudine, and dolutegravir in a single pill. We're basically closing the gap towards what adults have been benefiting from for over 10 years, having a single pill that you can use to get your entire treatment. So if you go on the next slide, please. So pediatric ALD has been developed also very quickly. We were very hopeful that we would build on the success of pediatric DTG, but what we're seeing is very slow uptake. So far, there's just one country that has been supplied. There's a few countries in Africa and in Asia that have a registration filed, and one country has approved it. It's going very slowly. There's a few reasons for that, and we've tried to address those in a policy brief that we published a year ago. So we were hopeful that this was coming at the same time as supplies would happen, and we were even thinking that we might have been late. But in fact, only one country has supplied since we published that. So if you go on the next slide, and once again, so there's three main issues at play here. The first of all is countries, program implementers are afraid of wasting drugs. And that's a very good thing because we're not changing the drugs themselves, we're changing the formulation. These are the same drugs. So of course we shouldn't waste that. We were allowing waste when we were transitioning from suboptimal to something better. But now it's the same thing. What we're improving with pediatric ALD is the supply chain. It's going to help with avoiding stockouts, avoiding perhaps single therapy of some kids when some drug run out. It's also going to help big time with adherence and ensuring that caregivers don't struggle with handling two different pills. The second issue is cost. There has been some concerns that this drug is more expensive than the single pieces. This is true by some extent, but the supply chain, the delivery, and the ordering in country but also internationally for shipping is going to be cheaper because you don't have two sets of pallets, you have only one. So there's economies of space in the bottling, and at the end of the day, it's the same price. There was an analysis by USAID that showed it's exactly the same price, and that's at launch. In a few years' time, we will have PLD price having gone down, as we've seen for all other drugs in the HIV response for over 20 years. The third item that's a concern is treatment transition fatigue. We've asked caregivers, we've asked program implementers, countries to change drugs over time again and again. It's not a bad thing, it's a good thing. We're doing this because the treatment is better. We're getting something that will help children thrive, and we're helping them have equity in health outcomes. So they're going to be benefiting and say, well, it's a lot of trouble to change the supply chains. It's going to be complicated. Yeah, but we work for the kids, right? So it's important we do that transition. I want to come back on the included in the policy brief that I showed in the previous slide, an algorithm to help countries plan for this. It's basically how to match one stock with the other one. If you have more of the ABC 3TC, you might you might order a bit of DTG single and the other way around. So you balance, and then after that you transition. And I think that's my last slide. So, and we'll be able to answer any question on this. But I think that the take-home message here is that there's an opportunity for transition. There's a few advocacy things that you can do. Ask your countries about the plans for transition. Share resources like the ones I've shown with them. Tell us at GAPF what are your plans, what are your challenges, but also what are your success stories, so we can share those with peer countries. And if you struggle with product-specific issues, you can reach out to MPP. Of course, we're working with the generics on these products. Thanks very much.
Thank you, Sebastian. We are going to give the floor to Teresa.
Thank you very much. I think I wanted to start by agreeing that the caregivers and the healthcare providers really do want this drug. And they are very excited and keen on matching with the adult population in terms of drug options. But I thought let me just bring the experiences from the healthcare provider and probably highlighting the key challenges that we see when we're doing transitioning. And I think the first thing would be understanding of the drug changes, having information and knowledge of what has changed, what is new, because people tend to attach more to the drug that they are used to because they know it and they've been using it for some time. So the key here is we definitely need to have more capacity building trainings and job aids, even if it's IEC material for the community side. And I think another key issue would be the treatment literacy gaps that we had seen from the caregivers as well. Treatment literacy in a sense that they need to understand and have insight of how this will benefit their children. Because I think in one of our thank you in one of our sessions yesterday, one mother had highlighted, one caregiver had highlighted that my role as a caregiver is to protect my child. So if I don't see how this drug will assist or benefit my child, then I won't give. So basically, we definitely need to close those treatment literacy gaps and make sure that they all understand. The treatment literacy goes with the myths and understandings. What do they know? What do they hear outside? And what is a healthcare provider able to educate or give information on? Again, another key thing would be the family involvement. In terms of including the fathers as well. Because remember, we know in mostly in our African countries, we know that a caregiver doesn't necessarily mean the biological mother. It could be anyone who's responsible for that child. And I think wanted to also include the Sebastian has spoke to that the issue of supply and making sure that we have enough stock, the processes that needs to be followed by the facility, the country, or even the district itself to make sure that you do have that stock at hand in our facilities. Advocacy and social mobilization gaps. We've seen this through our transitioning with PIDS to TG, where it was kind of confused with the TLD for adults. So there's definitely need for social mobilization, education, campaigns, social dialogues in understanding what is PIDS TTG or what is ALD in this instance. But again, we cannot emphasize the issue of funding gaps for pediatric HIV. The need for us to be able to do all of the above that we had highlighted needs funding and definitely a focused funding for PIDS HIV. But I also want to include, importantly, the community-led monitoring, because I think that is our vehicle that we would use together with the Global Alliance forums in countries to make sure that the multi-stakeholder approach is maintained and also every stakeholder within that forum knows what they're supposed to be doing, because we've seen a lot of best practices work that's done by different stakeholders, but it's just not gelling together. So the minute we have a community monitoring that knows what's happening in communities, then they can then advise how do they want to be served as a community. So I think that becomes important. I won't dwell much on this, but yeah, I just wanted to highlight information, information, information. Thanks.
Okay, thank you so much, Tabitha. So we are going to open the floor for questions. So we know that we have the drug, the PLD is available. There is some concern about the introduction of the drug at country level, but we have good supporters who are communities. So what is your thought in terms of improving access to PLD?
Thanks very much. It's been really informative. I'm just wondering what the bottlenecks are in terms of the responsible authorities who are importing the drug, and what the bottlenecks are. I mean, if only one country has adopted this, in a sense, I understand that the community mobilization and awareness needs to happen, but actually, too, does the introduction by the authorities responsible for importation. So it seems like there's actually advocacy that needs to be done there. And in that regard, what can we learn from the introduction of pediatric DTG that has been so successful that we can try and do the same with regard to PLD?
Yeah, I'm happy to take that question. So I mentioned the issue of wastage. What we realized that a lot of countries have lots of stocks of DTG single or ABC3TC dispersible, and so they have to go through those stocks. What we've learned, I think, perhaps we need to go back to that transition again. There were things that were done when we were about to transition from lopinavir to dolutegravir, like making sure that if their country has too much stock and doesn't want to waste it, they exchange it with another country. And Global Fund and PEPFAR can facilitate that. So right now we have countries that have way too much dolutegravir single. Some others that will have too much ABC3TC. Maybe we can balance this out instead of going through the entire stock of the biggest line, right? So that could be something to be done, but it needs coordination. It needs the trust. But we're lucky in HIV, we have procurement agencies that span a lot of countries, so they are best place to do that, I think.
Is advocacy needed there? Well, I just want to check. I mean, so you're saying that we've got the structures and the bodies that can do that coordination. So the question then is, why aren't they doing that? And what is needed? Is it advocacy that's needed to really try and make sure that that happens? And and then it's trying to make sure that, for example, the Global Alliance champions and others that are working and advocating on this need to get together and have a coordinated voice to make sure that this happens as a general international approach.
Yeah, no, I think you touched on advocacy, which is quite key. So probably one of the experiences we've had with PEDS DTG in South Africa is making sure that we advocate in all platforms, even if it's not only the platforms for PEDS HIV, so that other people could also understand, because you understand that it's a system that includes other programs as well. In South Africa, we've got SAPRA that would need to approve the drug itself for it to be able to go and tender, and all of those processes before we can say, yay, we can continue and have. So to cover those processes and to make sure that those processes are fast tracked, we definitely need advocacy. And advocacy cannot come only from the champions. It needs to be in all the different platforms. Yeah. Community is one key forum that could drive advocacy campaigns, advocacy, social mobilization as well, in terms of mobilizing even the political will to drive through the provision of the drugs.
maybe I'll just add something about this. So Patricia mentioned that we have a task team under GAPF that's looking at specifically the out, and we haven't discussed this at all. In fact, so your comment was spot on, and I'm gonna bring it. We're gonna bring this back for discussion and see what these other organizations can do.
And probably just to add, we already have the support of WHO, UNICEF, PEPFAR. They release some note to each country team in terms of monitoring the access on country level, make advocacy to have the drug be introduced at country level. So the process, this activity already started, but as you said, we need to improve it, and they are planning to have some joint visits at country level in country where we are going to have a lot of difficulties in terms of introduction of the drug. The joint visit will happen at those within these countries.
One of the things that I have not heard at all on this DTG story is the role of communities of faith in advocating for this, and the role of the Vatican Initiative. Almost absent in all the conversations. This advocacy needs to be on the agenda of the Vatican consultation in December, because that's what will make it happen.
I won't be responding to that, but I just wanted to say I believe the Global Alliance Forum is a great platform for this, because we also have the civil society sectors, and faith sector is one of the sectors that's represented there. So again, it's an issue of insight as well, in terms of how does the faith sector sees this benefiting, and so that they are able to then drive the message. Yeah, but I'm just saying the Global Alliance Forum is the best great platform.
Again, that's a comment that's very relevant. I think 2 days ago, I was having conversations exactly about this, about bringing this kind of discussion to faith-based organizations, to your very large networks. The same with EPN, the Ecumenical Pharmaceutical Network. So yes, we need to do that, and I hope we can follow up after this very busy week.
Thank you so much. And yeah, this has really been very insightful. I actually just have two, a comment and then also a question. So the comment is just, I think in the South African context especially, I would love to see the communities knowing about this even before it becomes available, because I think we've really started seeing that if communities start lobbying for what could be possible, their voices can be heard. And I'd love for us to make this almost like a really big marketing approach, even before it becomes available, to also lobby the voices of the people to make that available. And then I just also was a bit interested in what, Sebastian, what you'd said about the cost benefit analysis, and how we could prove that even though on a dollar basis, the cost of the two drugs versus one drug is the same, do we have a document that basically outlines how the benefit of adherence, viral load suppression, and what that benefit is in terms of people lives changed, but also the supply chain and all of that? Because I think those discussions are going to be important, and we also need to stop ordering the wrong stock now if we want to have this available in 6 to 12 months from now. So I just wanted to know if those resources are available and if they can be shared. Thanks.
So on the question regarding the price analysis, that's an analysis that USAID did. It was shared in the task team, so I suspect it can be shared more widely. It's a presentation, so yeah, we can follow up on this. On the benefits of fixed dose combination and adherence, I think this is kind of an assumption of everyone in HIV for a decade. It's very difficult to find very hard evidence around that. But I'm going to hand over to Tabisa in case she wants to comment on this.
I think we will definitely find those resources and share with the colleagues. Yeah, no, but also the marketing issue that you just raised, because I think for South Africa, we know the issues around the new transitioning that we are in currently, because we're still very brand new in a sense, yeah, for PIDS DTG. So again, the issue that I had raised earlier around understanding the drugs and the difference, because we moved from Caletra syrups to pellets, from pellets to PIDS DTG. Now we definitely have to move to ALD. So it's quite a fast-tracked move. So it will definitely mean that communities need to know, also the healthcare providers themselves, so they're able to give out the message or the proper messaging. Yeah. Thanks.
Question? Okay, we are going to move. Probably after that, we are going to have other questions. So, Mary, you have the floor.
Thank you. So what I would like to present briefly to you is our advocacy brief at GAPF. Thank you. So we talked about the importance of having adapted formulation of medicines for HIV treatment for children, but at GAPF we also work on all pediatric formulation for all different disease areas. And we know that there are silos in product development across different stakeholders and across different technical areas of work. And we know also that drug formulation are often not adapted to children's needs. So they're often too big to swallow, they don't taste good, and they're difficult to use. Next slide, please. So there's been progress, of course, but there's still much to do, and there's been next slide, please. And there's been lots of international policy mechanisms that have been advocating for better meds for children. So here is just to show you that at the last World Health Assembly, the World Health Assembly in May 77, there's been a resolution adopted to accelerate progress towards reducing maternal, newborn, and child mortality. And in this resolution, there was two operational paragraphs mentioning specifically GAPF and the importance of having pediatric formulation. But coming back to our advocacy brief and what we do at GAPF. So we were discussing with civil society and communities. We have a dialogue where we engage regularly with these groups. And what we decided to do is to work on an advocacy paper where we would where the idea would be to align our messaging and find like advocacy actions that where we would be aligned all together. So we prioritizing efforts and making sure that we're all aligned in the same direction. The second one is coordination and basically making sure that we're all working together. The third one is incentivizing action. So this means including removing any hurdles that might exist in terms of regulatory challenges or market entry, as well as incentives. The fourth one is to ensure accessibility, because we may have the best drugs, but if these are not accessible, then there's no point. And the last one is investing more and better in having better medicine for children. So this advocacy brief will be available next month. It's currently at WHO for its clearance, and we will make it broadly available when it's published. Thank you very much.
Question?
The PALD is going to be an infant formula, or are we still going to, not yet?
I just can contribute. I'm Carmen Perez Casas from Unitec. Just want to contribute to that one, that there are other formulations that would be even more adapted to infants. For example, we are with University of Stellenbosch in South Africa, we are testing the way we could use an oral film. This is like a piece of scotch you put actually on the tongue of the babies, and it can dispense the dolutegravir medication, and that could be really something that could be a very good game changer for this population. So we are working on including in this oral film new formulations for infants. Because if I now that I have the microphone, if I can say one of the biggest challenges that we are all confronted with kids is that kids are not one uniform thing. I mean, they grow and they start, if they acquire HIV birth, they will have a full trajectory whereby they change and they need to adapt and they need to new medications. So not only they represent a very small size of the market, they are not uniform. So that's what we had realized with GAP-F and thinking about what is the actual journey we need to ensure that these kids have medicines. It's different journeys. You don't talk about one. It's not one market, it's multiple. It's fragmented. You have mentioned, Sebastian, for example, the coordination for procurement. There are countries that have very good shrinking numbers of kids with HIV, and some of them are in one age, others another, so that even the orders are very difficult. You cannot pass an order for 1,000 kids, and the next month, another country, another order, 1,000 kids. So everything requires coordination, even more than adults, because of this fragmentation.
Comment? No, so
I just wanted to come back on what Marie was presenting, the advocacy brief. The reason behind producing this was to create some kind of content that advocacy groups, organizations who are working interested in children that might not have material, might not have the talking points. It's a way to equip them with that, because what we realize is that very often organizations are focusing on a disease, and by default they focus on adults. And when you ask about children, they say, yes, of course, we cover children and we care, but the talking points are not specific. And so this is about providing some starting point. It's not going to be comprehensive. It's not the whole thing. It's very short, but it's really a way to engage in the direction.
That said, whilst a general advocacy brief and policy brief is a good idea, because this is such a fast-moving area, the importance of putting out perhaps a company on almost a 3-monthly or a 6-monthly basis to say what are the specific calls, what do we need to be doing now? And we've talked about the Rome Action Plan. There's going to be another meeting in November or December, and we do know that the pharma do listen, when they go to in the presence of the Pope. So that will clearly be an opportunity to make sure that whatever the specific calls might be in terms of formulations, or in particular new advocacy that's coming, that's needed at country level, in the sorts of EIC, the sorts of information that's going to be required. Let's get that available for 3 months or 6 months down the road, so that communities, the pharma, the procurement agents are all aware of their roles. And the beauty of the roadmap, as I'm sure you've seen, of the Vatican roadmap, is that every stakeholder's role is known, is rolled out, and everyone can see it on the website, and it's monitored. Yeah, so that there's a strong sense of accountability, and that's in part why the pharma and the diagnostics companies have listened and have followed what's happening. So yes, great. I'm really glad there's an advocacy brief out, but it does need the specificity of what needs to be said now and to whom, so that whether we're working in the Global Alliance or in the faith communities in Kenya with EPN or with whoever, that we're taking those messages into the right forums, so that it's like having a folder, but it's a ring-bind folder, so we can open it and put the right pages in. It's not something that's going to be fixed for the next 3 years. So it's a supplement every 6 months. Thank you.
Okay, thank you so much. Well noted that in addition to this advocacy tool, we need to be very specific with what we are waiting for each partner. So well noted. So
I'm tasked with trying to capture key messages and close. I'm not going to repeat what these panelists have said. It was really important. First of all, thank you already for organizing something devoted to children, because as you know, it's many times lagging behind as well in these meetings. But I think to start with, I heard that very key important words: advocacy, and thank you, and advocacy starting roadmaps that we collaboratively design for addressing the main barriers of children. This is so that's absolutely clear. But we also heard advocacy and people say this is a way. We know that even having the product is not sufficient. So we have for years organized ourselves in a roadmap trying to ensure the products are developed. And now we have this product, PLD. We have from Unitate, for example, supported many different actors so that the product could be available. And the product is there, and it's a good product for certain age bands. And we are seeing a very slow scale up yet. So it's time to switch from prior other alternatives. And it is really important, even if it's the same molecule. We know that access is also ease of use. It's time to switch. We cannot waste any time because it's been a long journey until here. So it's fantastic to have all your voices supporting that change. I think the coordination among all of the actors is extremely important. And also, there was something said which I think is really key. GAPEF is actually using HIV as a trailblazer. The same problems occurs in any other disease for children. And we are learning so much from HIV. We are a bit always the engine that moves the locomotive with other diseases. And those children have other diseases as well, not only those living with HIV. And so we are absolutely supportive from Unitate of all the actors and including this coordinating role of GAPEF to actually ensure we understand what are the hurdles at this stage and how to accelerate who has to be in the conversation each time. So this is very important, but of course money is the very important one. And the funding from the research to the uptake is absolutely necessary and for the uptake. So I think the solution passed by collaboration, that is absolutely clear, especially here with all the stakeholders. And I think I'm going to stop here because I think people are very busy and willing to move forward. But I think we have illustrated quite nicely. You guys have really done a very good job of illustrate the barriers that we have to confront. And not all of it is research and development. A lot of it is downstream on how we prepare from the first day, start preparing the countries, start informing everyone, sharing this product is going to come. How will you train? What will be the barrier? How will it be used? And that is extremely important. We cannot wait any single minute to have those products available. Thank you.
Thank you, Carmen. I was very quick because I see people was leaving. No, but that was great. And we had like a